The TABI program at the SAN started about 2.5 years ago, and we've done about 80 odd cases, I think, now. So it's been a reasonably good start, and so far we haven't had any deaths, which has been great. And maybe a lot of that was just good luck, but hopefully some of it might have been from intentionally trying to plan the way we started the program. And I guess because we started a bit later than many other people in the audience, we had the advantage of learning from others, and so I was going to try and see if I could pass that on in case there's anyone thinking of starting up a program. I think one thing when you're starting is kind of being honest with yourself about whether you actually should be doing this at your centre and whether you need to be doing it. Are you going to have enough numbers to keep the program going? In our situation, we were a bit concerned about that at the outset. Now we've got the opposite problem where we can't find enough time to do the cases. So I think there's certainly work out there, but I think you do need referring doctors, and you do need a financial strategy that's going to enable you to start the program and continue the program. There's no point starting a program if you can't continue it. And I think the referral base and the financial side of it needs to be acknowledged and sorted out early. And you definitely need strong cardiac surgical support at the hospital. I think particularly in Australia, where most of the audience is from, we need cardiac surgical backup as part of the criteria for the program. And it's essential that the surgeons are involved, as well as the cardiologists, and really a whole team approach, which I'll talk a little bit about. So those are a few big questions to ask at the start. And I guess one thing that probably also happens at the start is there's quite a bit of fear everywhere. And I think there are lots of people that are frightened when you try to start a TABI program at your hospital. Medical admin are scared because they have to the CEO of the hospital has to sign a form to say that they'll, go along with the guidelines for the TABI criteria, and they hate signing stuff. They're worried about whether it's going to cost them money or make them money. They're worried about some sort of risk that the hospital or themselves personally might be exposed to, what personnel they're going to need. But then even within the clinical part of the hospital, people are also a bit scared. ICU at our hospital was a bit anxious about what was going to be expected. Were we going to dump these horrible patients in their laps? Were there not going to be any surgical work anymore, or were they going to be just as much surgical work and then they'd be overloaded? Coronary care, similarly, are some of these patients going to end up in coronary care? Are they scared of looking after them? Anaesthetics, anaesthetists, not all anaesthetists are in any way used to working in a cath lab. And it's not a friendly environment if you're an anaesthetist a lot of the time. It's, your normal things that you want and may not be there. The nursing staff, the cath lab staff are very experienced with most of what needs to be done, but not all. And there are some new skills that are needed. You're going to do these in the cath lab, you're going to do it in a hybrid lab, you have to set up a new lab. All these things, require a lot of background work before you walk in there and do a TABI. And I think, both the cardiac surgeons and the cardiologists have a bit of a bad case of FOMO, fear of missing out. Oh, am I going to be the one doing the cases? Are the surgeon's going to do them all? The cardiologist's going to do them all? And that makes, can create issues. And I guess the patients might be scared as well, because if you tell them they're the first one that's going to be done at the hospital, they might not be all that thrilled. So I think one of the key things that we tried to do when starting this program was to actually manage this whole issue of the fear. And I think the main way you can do that is take the whole team, all those people that we've just talked about who are scared, try and take them on the journey of starting the program with you, rather than just turning up one day and say, rightio, we're going to do a TABI in Savo. So we were very fortunate to be able to go down to Monash Heart in Melbourne, who had a lot of experience, and we took a whole team down. We took nurses down, intensivists down, anaesthetists down, doctors down. It was great, and everyone thinks about these things differently. The anaesthetists think about things a bit differently from the cardiologists, and the nurses think about things differently. and everyone was able to learn from their counterpart. And everyone came back feeling a bit more relaxed because they were like, oh, that just looked pretty good. The patients looked okay afterwards. The person that's going to be doing, is doing the job I'm going to be doing didn't look stressed. And that can allay a lot of fear, I think, just by taking away the fear of the unknown. And look, I think the other thing is really keep the same team together, particularly when you're starting. You might only do a few cases on the first day. There might be another month before you do some more. You really need to keep the same guys together so that you're all learning in a proper way, rather than an ad hoc group of people that just comes together and leaves again, and everyone only does one thing once. Repetition's always good. So I think setting yourself up for success rather than failure has already been mentioned today, but I think it particularly applies to the TAVI type program. The other thing, probably, I think the Europeans have been way ahead of us with regard to heart teams. They've been doing it for years about all sorts of things. They have meetings and so on. I don't think we've been very good really about heart teams in Australia until TAVI came along, and that's often been the driver for setting up a heart team. But that is a challenge too. Who's going to be on the heart team? And I think it's great to have a lot of different people involved. At our heart team meetings, we generally have someone from each of those groups on the screen present, and and everyone's got something to contribute. We just call our anaesthetists instead of anaesthesiologists, but apart from that, it's a pretty accurate slide. I think the imaging is really important, of course, at these meetings. The pre-planning for TAVI, a lot of it's about imaging, and if you can have someone there who can actually help you with that, it makes a big difference. I think getting back to setting up for success, not failure, we've started a couple of new programs at the hospital, including left atrial appendage and so on, and I kind of like the idea of a soft start, right? Rather than going out and having a meeting with every cardiologist and GP that you've ever met before you've done anything, and telling them about your fantastic program and then having a bad outcome on the first day. How about do 10 cases of your own, your own patients that you've got within the group of people that are getting together to do the TAVI, and just do them and do them well. And then you can tell people, by the way, we've done 15. You know what I mean? And they go, I've done 15. Yeah. You know what I mean? I think that goes down a lot better than, do you want to send us a patient to be the first one? You know what I mean? If you're a referrer, you don't want your patient to be the first one. So don't make your referrers give you the first ones. Come up with them yourself. And start with the easy ones, that pick the low-hanging fruit. Pick some patients that look healthy, right? That don't look like they're going to die when they have the procedure, and that have some straight vessels, and someone that a surgeon might have actually operated on, rather than some complete disaster patient who nobody wants to touch. Just don't do them. For the first 6 months, just don't do them. And I think something else happened to those patients before you started, so you don't have to do them. I think proctoring has been shown to be successful, particularly in the left atrial appendage space. There are a large number of registries that have come out looking at results from early centre performance in performing, say, left atrial appendage closure. And their results are excellent, and basically that's because they get good proctoring. And I think the same thing applies to any procedure. If someone can stand next to you who knows how to do the procedure and help you, your outcomes are going to be improved. The other thing too is if you're going to get a proctor, you might want to do what they say, and that doesn't always happen. But I think it's a good idea to listen to them, because chances are they've already had the problems that you're waiting to have. The other thing is, I think industry is massive help to starting any of these structural programs. It's already been done, right? You're not going to be the first to have started doing TAVI at your hospital. It's been around in Europe for years. These guys have got a pretty well-worn pathway for how to start a program. So let them help you, and the other thing is clinical specialists from industry have a lot of detailed knowledge about the device that you're going to be using, and they're helpful people. I think the other thing too, just simple stuff like plan the cases, book regular lists, set yourself up for frequent repetition so that when you start doing something, you practice it and you do it better. Present all the patients at the MDT, keep the PowerPoint slides, make it sure everyone can read them. We look at them again, before the case. We sit down before we start, we get out the slides, we present it at the MDT, we get out the CT and the other imaging, and we have a look at it. Look at the CT yourself. And we also admit the patients the night beforehand, and that's proven to be useful. We've cancelled a couple of cases because somebody had something wrong with them that was picked up when they turned up the night before, and maybe the anaesthetist popped in to see them and said, "Oh, Jason, by the way, their INR's 5. Oh, you know what I mean? Rather than finding out on the day and it all being a bit of a disaster. So it's a bit harder on resources, but on the other hand, maybe not in the long run. So of course, we want to avoid the whole train wreck scenario, and I think the things to think about there is, have you actually thought through what's going to happen? Are the surgeons really going to back you up? Are they really there? Are you going to use ECMO as some sort of backup? If so, do you know how to use it? Is there anyone at your hospital who knows how to use it? Where's the machine? Does it fit into the room? If you're going to move the patient to the operating theatre, does it fit in the lift? You know what I mean? Silly stuff like that. But it's better to find out beforehand rather than when the patient's on ECMO and you can't fit in the lift. And then I think the other one, the other main complication you're going to see in the lab really is vascular stuff. And a lot of that, I think, we should be able to manage ourselves as interventional cardiologists. But a lot of, there's no particular reason why necessarily you might have ever put in a covered stent before. So you need to make sure that you have, or if you haven't, that somebody's going to come and help you to put one in. And I think, being able to deal with an iliac perforation and pop in a covered stent and fix it up in 5 minutes versus asking a vascular surgeon to delve around in the patient's pelvis, it really should all be being managed in the lab, and you need to make sure that you can do that. But also that there are some covered stents. We had one the other day where I realised afterwards that the guy who brings the covered stents for us, they're not on the shelf, takes them away again at the end of the day. And fortunately, the day when I did need one after he left early, and so he decided to leave them there. But it was only by chance, right? So make sure the actual equipment that you need is physically available. All simple stuff, but better to think about it in advance. The aftercare is really important. If you can write a protocol or steal a protocol, then it makes everyone's life a lot easier, because then the staff that are looking after the patients post know what they need to do and know what's expected. The patients are all old and crumbly. Geriatricians look after those kind of patients. Maybe we should get a geriatrician to come. Again, simple, but it can help. So look, I think overall, I was just going to mention about the database as well. I mean, in Australia, I think the Accor database is really now a requirement rather than an option. But it will enable us to get some good quality data, and access to that database will allow us to publish some good quality research, and it can potentially improve the profile of your hospital. And then I think, as we said before, maybe soft start and then a ramp up. Once you've done some cases and things are good, you can then start telling lots of people about how good your program is. So I think overall it's great. If you haven't started a TAVI program, I think have a think about all these things. It's certainly doable. There's work out there. But I think, as usual, if you can plan these things and involve all the relevant parties early on, it seems to make for a smoother process. Thanks very much.